hours later in their clinics. All right. So as you guys have been telling me, I've been hearing you guys are having a lot of fun and amazing experience learning from the power sessions of TG. As I've heard, you like it even more than the classes on the app. So as we also talked about it in the yesterday's advanced file classes, we are going to talk about more powerful topics. So is everyone excited for for the coming weeks if we do more power sessions? Would you like that? Yes? Just a yes or a big yes? Do we want more power sessions? Does it give you absolute edge and then absolute fun and ease and confidence in memorizing the keywords with the power and emphasis that we put on every concept? I like it. All right. So I'm gonna announce 2 or 3 topics, maybe, and maybe because we have a lot of time before exam, I could maybe do all of them, but maybe with your votes, I can sequence them accordingly, right? So I'm gonna put that poll on the WhatsApp. I'm gonna put the poll on the Facebook, wherever you guys are, wherever you follow me. Just go and maybe vote your preferences there. And if at all your preference doesn't get chosen this time, please know that I will only be posting very, very powerful topics. So whatever is the winner topic is, it will absolutely give you the edge in the exam, right? And that is what we are intending to do. So, and I'm really, really happy to know that everyone is enjoying the power sessions and it's coming all together. You're telling me that now you look at the questions and you know the anaphylaxis and you know where to call 000 first and where to give the drugs first. You know myocardial ischemias, myocardial infarcts, the strokes, the signs and symptoms, right? Absolutely, the cardiovascular emergencies, the syncope, and the allergies, starting from the aortic area, then angioedema, and then your anaphylaxis. Is that correct? All right. So now we have to do the third part of all the allergies, which is we were left with the ocular emergencies and the respiratory emergencies, right? So I'm going to start talking about ocular emergencies first, and then we'll move on to the respiratory ones. And respiratory emergency is crucial for the exam. Would you believe that? That asthma questions, asthma histories, they keep getting asked in the exam. So should we absolutely by heart know the mild, moderate, and severe episodes? Mild to moderate, and then the severe asthma attacks, and the minor nuances, how they differentiate from each other, how to choose within the options with all the similar keywords, but just one specific word setting apart the correct option. We did a lot of new questions yesterday in the advanced file, didn't we? We did about the inhaled object as well. We did a lot of infection control guideline questions. And what did we see? Did we notice a pattern that the options were so closely framed, right? That majority of the wordings were similar, or all of them were the possible part of the management, and just one specific word would set them aside from the correct option, right? And we did talk about the attention, right? The attention to the details, as I have been talking about it, what you really need to score high, maybe 75, 80% in your ninja mocks, or maybe 90% in your ninja mocks. This is the attention to the detail. And TG requires the same skill and acumen to pay attention to those details, those keywords. Because if you read and no one emphasizes on it, or no one brings it or puts a spotlight on those keywords, it is so easy to miss out that information from TG, right? So that's what we've been doing in the forms of advanced file, in the form of MegaMaster, because that gives you the exact exercise that you need to flex those muscles, right? To identify the keywords. Isn't it right? but it goes hand in hand. The more you go towards questions and you leave aside revision of ODEL and TG and ICG, the guidelines and text per se, then you miss out on the newer concepts and you're focusing only on the repeated concepts. And in the exam, the newer questions will get you. And the more you go towards the textbooks like TG and ODEL and ICG and guidelines only, and less you practice for the self assessment, the lesser or more mistakes sometimes you do because of the lack of the practice and having the eye for the detail. That's what happens, right? The more we get inclined towards one nature of preparation, we suffer in the other. And that is why I've been emphasizing to balance both kinds of preparations. The more you need to read and review and repeat the text, the more you need to watch the classes and revise the concepts that we do in the classes, even more you need to do the self assessment. So from the yesterday's class, I assume you all took away a very valuable lesson of the self assessment, and I'm sure you're going to share the results with me. And I got, after the class, I got amazing response from you all when you sent me your goals and your desired outcomes of how you're going to prepare for the self assessment, right? All right. So now let's start with the ocular emergencies, how you're going to manage those questions. And because it has not much been asked, so it makes it even more so important, because any question that will come on this would be a newer question. So we need to know everything in detail. And we need to know all kinds of practically possible ocular emergencies in dental clinic. And they can be chemical, or a foreign object, or a penetrating object, right? These are the three possible injuries. One is chemical, other is a solid foreign object getting lodged in the eye, or a penetrating object which will have a penetration effect, which will penetrate the eye tissue. Foreign body would be superficially on the cornea or on the eyeball, but not penetrating inside the tissue. Penetrating and the foreign body injuries are different in terms of one lies over the surface, over the tissue, and penetrating has penetrated and broken the integrity of the tissue. Is that correct? So those are two separate injuries. And chemical would be particularly mostly solution form in dentistry. Is that correct? So a liquid injury, but there can be mild to very, very strong chemicals involved in the treatments, depending upon what procedure is being performed. So endodontic irrigating solutions are the most common ones that you might be using. And some of them can be highly alkaline, and the pH can be really damaging to the eye. They have caustic damaging effect to the eye, right? And you can totally minimize these kinds of injuries in wearing eye protection. So suppose you can get a question like that in the exam. A history is given, an injury has occurred, and a professionalism question can follow. How would you avoid this kind of injury in your practice? Have you seen questions like that? We have seen question like that in the penetrating needle injury in the hepatitis B patient, right? That case we have seen. In the ODEL case, we have seen where the foot penetration injury occurred. So we have done multiple examples and practices when we have done the injury protection protocols. So there's these kinds of questions do come in SBQs where the incidence has already occurred and professionalism will ask you how you can prevent it. And in infection control guidelines, also, we have learned that eye protection is extremely important, not just for these injuries, but also for the infection prevention, right? So in both the terms, wearing eye, so if the option gives you, now just you prepare TG, but you ignored that concept in ICG. That is how the dots are connected. I teach you, right? Connect the dots, connect the dots. So if example, the question comes, how are you going to prevent this kind of injury? And the options were given, and one says, okay, the wearing eye protect, you'll educate the patient that wearing eye protection could protect such kinds of injuries. And the other option says wearing this kind of eye protection could prevent the patient from contamination and injuries. Because we have done all the guidelines and we understand that we are connecting the dots now. So we will choose the latter option, right, Naveed? Right? Absolutely correct. So that's how the attention to the details and having that eye and connecting all the concepts that we have learned is extremely important. And the framing of the questions and the options can be extremely similar. So that is why pay attention to all the words. Okay? And whenever you're passing within your DAs, within your staff members, any of such solutions or instruments or chemicals where the injuries are likely, you would never pass them over the patient's face. Is that correct? So chemical eye injuries have to be managed. For example, an SBQ comes where the injury has occurred, right? The most dangerous are your alkaline solutions. Similarly, are also your acidic solution. We have done questions on TCA or not? TCA acid questions we have done. Extremely strong acid. And we saw the ADA reference as well. The conference was conducted on it. The video was shared as the reference on the group. And when you are performing procedures with a higher risk solutions or higher risk in components of whatever the treatment is, you should always keep their neutralizers or whatever enzymes or any kind of neutralizers that work with them, right? So any dentist who is an expert of using very strong strength instruments or solutions for the patient should also keep the neutralizers handy while performing those treatments so that in case of any emergency, immediate antidote can be provided, right? Immediate management can be done and the patient can be saved from a severe damage. Particularly if the question gets asked, alkaline solution will cause what kind of necrosis, right? Does it cause ulceration? Does it cause necrosis? Does it cause probably like a burn? So all these different wordings and options can be given to you in the exam or not. So then the liquefactive necrosis would be the ideal word of choice. Is that correct? So any kinds of the burn injuries or ulcerative or any kind of epithelium break injuries mentioned to you, you will memorize and remember this keyword or not. Liquefactive necrosis and able to identify and mark it as the answer. Now these are easy peasy questions and scores available to get in your kitty or not in the exam. But if you're not paying attention to every word and every detail, you can miss that out or no. Now, how are we going to manage the chemical eye injury? So, if a chemical injury to the eye occurs, you will stop the dental treatment first, as goes with any injury. You will have to stop the treatment. And here, you don't need to call 000 first because there is available a method by which you can prevent the damage, right? So you will first immediately start irrigating the eye with the water because neutralizing the potential irritant is the most important thing. So immediately irrigate the eye with water and then keep the eyelid open, right? And then remove the contact lenses and continue the irrigation, right? And do not use eye cup. Where do you use eye cup? Eye cup you will use for the penetrating injuries, where you actually need to protect from any external object or even patient touching it by mistake also or moving the object. So remember an eye cup word if you see in any option. If you see the word eye cup in any of the option, where would you use it and where you won't? Eye cup would not be used in a chemical injury, but eye cup would be given in a penetrating injury. Is that correct? Would you remember it like that? Is it easier to remember it like that? If it's a chemical injury, no eye cup. If it's a penetration injury, we will choose the option with the eye cups, right? And if it's a minor irritation, then you will send the patient to the hospital or the medical specialist for the review. And if it was a very strong alkaline solution and you see that there is extremely inflammatory response in the patient, excessive injury, then you will call emergency and you will continue to irrigate till the help arrives, right? And first thing you will do when the help comes is tell them which agent caused the injury so that they can also utilize the similar neutralizer which works best against that kind of solution. That is why revealing this information is mandatory or not. So I give you the options in the exam of irrigating and then calling the help and sending the patient to the hospital, or irrigating and calling the help and informing the paramedics about the agent. Would you be able to pinpoint even more detailed option or not? Are you going to miss out on these words or not? And you have been noticing, we have been seeing that in the advanced file or not, that in infection control guidelines and in the where the triaging of the treatment is required, where the sequencing of the treatment is required, all these details are given and some part is missing in some of the options. So ICGs and emergency sequencing and the steps that you will follow. These kinds of managements and questions can trick you and will trick you with the keywords. And many options would be similar with some of the component missing. Is that correct or not? That is why knowing the correct sequencing, knowing the absolute correct protocol and guideline for these situations is mandatory. So informing which chemical has caused the injury is absolutely important to tell the paramedics. Now, if it was a foreign body which got lodged on the surface of the eye, which could be a piece of a filling, it could be calculus, it could be any fragment from any dental material that you have been using. It could fly off and get lodged on the eye surface. The moment the dislodgement happens from your operation, wherever you were operating it from, and it gets lodged in the patient's eye, whenever that happens, as soon as that happens, you will stop performing the treatment. And again, just like the chemical injury, you will irrigate, right? Whether it's a liquid irritant, which is in the chemical injury, or it's a solid irritant, which would be in the foreign object injury. In both the situations, stop the treatment and irrigate. And you will, in both the situations, keep the eyelid open. In both the situations, you will prevent touching anything. Do not attempt to remove this solid object. Even if you think you can try to pull it off, the more you try to move it, the more corneal damage you can do. The abrasions, the microscopic abrasions can happen on the eye surface. That is why you will not attempt to remove the foreign body. Is that correct? Because of the physical movement, it can cause more friction and abrasions on the surface and can be permanently damaging as well, or more damage than it would cause by just being there. The only way you can help it getting dislodged is by the irrigation. Is that correct? And if you can't dislodge it, you will send them to the emergency department, right? And if the patient still has any ongoing symptoms, even after removal of the irritant, still you will send them for the analysis because that means the injury has occurred. So even if the foreign body comes out, but the patient continues to have irritation in the eye, would they require medical assessment or no? And review or no? So maybe you can only keep the patient in your practice and continue the treatment if the foreign body got dislodged lodged in the eye, and with irrigation it fell out and patient is asymptomatic. There is no need to call 000, right? There is no need to call the 000 because foreign body lodgement is not giving an immediate threat. Chemical can cause an permanent damage to the eye. Liquefactive necrosis, is it reversible? Is it healable? No. That is why the chemical injury is more damaging and more severe as compared to the foreign body loss, because that's a superficial abrasion or damage. The severe foreign body injury would be when it penetrates the eye tissue. Is that right? Because that's where it has broken the integrity. And once it has penetrated, now there are nerves, there are arteries. Is that correct? there is retina. So there is a lot of sensitive tissue there which can be compromised for life. So amongst the three kinds of eye injuries, calling 000 is important for chemical and penetrating. Would you remember that? Not just a superficial. These are minor nuances which you have to remember and memorize. So in the penetrating eye injury, there is no particular dilutant or solution or water also that you are going to wash off. That is why the calling 000 will come on top after stopping the treatment now. Understood? Just like other things where there is no life-saving aid available. Similarly, for the penetrating injury, there's barely you can do to protect that. That is why stop the treatment and call emergency. Would you remember that one? Whereas in your chemical injury, because there is water and it has a full potential to dilute it, right? And save the patient from a major damage. That is why stop the treatment and irrigate it and then potentially call emergency. So remember in the yesterday's class when we did the inhaled object and the calling emergency was there, positioning was there, and then we were applying the sequencing concepts. So it is not that it is not important. Every of the step that I'm telling you and all these three classes are available on the app, on the Facebook page as a live recording. You need to review these classes. You have to go back and watch them again and hear me saying those crucial concepts so you can take with yourself in the exam. Now here you do not do anything else. Yes, Kumari, the public sessions recordings are also available on the Facebook, right? So here you're not going to either attempt removing it or irrigate it or prevent the patient from rubbing the eye. You're going to do stop everything. Just stop. Don't irrigate, don't rub, do not attempt anything, and simply put the eye cup, which is a polystyrene cup, basically, an eye shield, so that nothing touches it. And tape the eyelid here, tape it around the eye socket, right? Then you will also try to keep the patient calm because it can become an extremely tense situation for the patient as well. Something penetrating in the eye is not a small emergency. It can give a more of a panic situation as well. And then again, because the object is still there, you're going to tell the team that what kind of instrument that is, or you can show that the instrument to them. So even in the chemical injury or in the penetrating injury, you're going to tell the paramedics about what the source of injury is, the chemical nature and the instrument nature, so that they know what they're dealing with, whether it's a smooth surface, whether it's a corrugated surface, right? Is that correct or not? In terms of files also, whether it's a spreader, which is smooth, or whether it's a corrugated surface. So they are also prepared what nature of the injury would be, how much damage it could create, or it could be a burr as well. I mean, let's hope never that happens to anyone, but it could be anything that flies off and penetrates and gets into the eye, any sharp object, right? So these are the three kinds of eye injuries and ocular injuries you understood with the terms of the physical irritants, external irritants, chemical, foreign object lodged, and your penetrating. In the penetrating, important point to know is the eye cup and calling the emergency first, telling the nature of the instrument. In the chemical injury, the most crucial point is stop the treatment and extreme irrigation, right? And then calling the emergency and explaining the nature of the chemical to the paramedics. In the foreign object lodged, again, irrigation, and irrigation. No need to call emergency, usually because it's a superficial lodgement. It goes off with that. If it doesn't get dislodged, send them to the medical emergency review. But if it gets lodged and still symptomatic, again send them for the review. But if gets dislodged and not symptomatic, you can maybe take a deep breath and continue with the rest of the day, considering how the patient is feeling as well. Agreed? All these could be the possible questions. What will you do next? There was a foreign object lodged and you irrigated and the patient is still rubbing, is still feeling itchy. What do you say? You're almost halfway the treatment, you want to finish it. The patient says, no, I'm worried, I'm tense, he seems agitated. The other option is go send them to the medical review. What do you do that? And these kind of questions you're going to get. Yes, send them to the medical review, even for the slightest symptom that they may say, Navid, right? Even for the slight itch that they complain of, or even a slight irritation that they may say, even after getting the object dislodged, you're going to send them for the review, won't you? All right. So other crucial thing that can happen is a unilateral blindness. And that can happen either with the local anesthesia, which contains adrenaline, or with your dermal fillers. And this will happen with the intra-arterial injection. So a very crucial question that can come is, what can cause the unilateral blindness, right? IV injection, intra-arterial injection, intramuscular injection, retinal injection, for example. So you're going to choose the neural injection, right? Injection into the optic nerve, injection into the intraarterial ophthalmic arteries, right? So are you going to choose correctly or not? So the unilateral blindness major cause is the arterial injection, not venous, not neural, not directly into the tissues, not retinal. Would you remember this one? Is a good question to remember or no? Wonderful then. So it's an intra-arterial injection of the lignocaine or any other local anesthetic. Predominantly, the vasoconstrictor is the agent that constricts and leads to a temporary spasm in the artery, leading to a temporary blindness, right? And it will usually happen unilaterally only because you're injecting LA on the one side of the face, right? So there's no way of getting it into the opposite side artery. That is why it will always be unilateral. Is that correct? So ophthalmic artery is mostly related. This unilateral blindness is related with the blood vessels only. The vasoconstrictor related Kumari is always going to be temporary in majority cases because adrenaline will then be uptaken in the body, right? Is that correct or not? It's an indigenous component. Adrenaline is naturally found in the body also. Your body knows how to ultimately metabolize it and utilize it, right? It's nothing foreign. It can't cause an anaphylaxis or a permanent damage. It's adrenaline. Your body is used to adrenaline moving around in your bloodstream, but not at this percentage or strength. Is that correct? Yes, it is because of the wrong administration of the block. It would be because of the intravascular injection, Munira. That is why what do you do? What can you do to prevent it? Always aspirate, right? Perfect, Ria. And usually after the adrenaline effect wanes off, you will have full recovery of the vision. That's why. That is why if the unilateral blindness injury occurs, it would be best, right? It would be always best to have through the LA. The worst kind would be to have from a dermal filler. Because a dermal filler, what have you injected? Have you injected something natural, indigenous molecule like adrenaline? No. You've injected what agent? Hyaluronic acid. Is your body able to fight that off, reuptake it, and have no damage whatsoever? No. The damage that hyaluronic acid is going to cause in the artery would be permanent or temporary? That would be permanent, right? And that is why it can lead to a permanent vision loss as well. So that is why the dentists who are doing the cosmetic and the facial aesthetics treatment, giving the injections, the dermal fillers, or doing the facial aesthetics, they should always be familiar with the use of the counteracting agent, right? To reverse the effects of hyaluronic acid by using hyaluronidase. They should keep that handy all the time. That's why when we did the TCA injury, the TCA, the high strength acid injury, you're supposed to keep the alkaline solution handy, the bicarbonate solution handy to neutralize, right? Perfect, Ishani. We've done that. You've seen the reference, you've seen the video as well. When you're dealing with the high risk solutions, high risk components, you're going to keep their antidotes or their neutralizers handy. So when you have a unilateral blindness after LA injection, you would stop the treatment and call the emergency still, because this can be even still severe, that and it can still cause loss of consciousness in the patient as well, because we don't know that this arterial injection, the adrenaline can also spread to other arteries, cerebral arteries as well. Is that right or not? There is a direct communication, right, from the eyes into the brain through the vasculature as well, and through the neural tissues as well. That is why when you inject adrenaline in the intravascular tissues surrounding the eyes, so that the ophthalmic arteries are also affected, that can also be transferred to the cerebral arteries. And when it happens to the cerebral arteries, or any kind of spasm or a reduction in the blood flow, because you reduce the blood flow with adrenaline, that's what you do, right? So if to the vital organs there is a reduced blood flow, that temporary hypoxia, or if it persists, it can lead to even damage, transient ischemia, and that can be an ischemic stroke as well. That is why even after injecting LA containing a vasoconstrictor leading to a unilateral blindness symptom, you would immediately call 000. You will not wait for adrenaline uptake to happen. That will take hours. Within that hours, it can spread to the vital organ arteries and can lead to or either hypoxia, temporary with reduction blood flow, or transient ischemia. Ischemia is the reduced blood flow, and to any vital organ, be it your cardiac tissues or your cerebral tissues, that can become life threatening or not. That is why, for the management of unilateral blindness after the LA injection, only two things: stop the treatment and call emergency. That's your best bet, and you hope nothing like that happens. You really, really pray to whoever you want to help the patient, and nothing else happens beyond that, so that the adrenaline is not transmitted or doesn't go to the other vital arteries. Is that correct or not? We don't want that kind of adrenaline in the circulation, right? And with the dermal fillers, again, you will stop the treatment, call the emergency, and you will note the time of the onset of the blindness as well. And while you're waiting for the help, you will assess for CVS. Will you remember this mnemonic, CVS? So you will check for cutaneous symptoms, you will check for visual symptoms, and you will check for stroke symptoms. Cutaneous, visual, stroke. Cutaneous visual stroke. Would you remember this? If exam question comes, the patient cannot see from one eye, and you did the dermal fillers, or anybody in your staff did the dermal fillers, you've called the emergency, while you're waiting for the help, what are you going to assess? And they can give you tens of different options. Would you remember? Cutaneous visual stroke. CVS. Cutaneous visual stroke. Would you remember these three words? Always. Now imagine, have you been reading TG? But tell me, did you pay attention to these details till now? Ever? In the entire medical emergency chapter, did you ever look at it this way? The way it can get asked, the way you have to choose the best options, the way you have to prioritize something, the way you have to, why you're prioritizing something, why you're not prioritizing something. And now, because your heads are opened to this perspective, wouldn't it also help you to always prepare everything in TG like that? Doesn't that come to you? Doesn't that skill, isn't it that with just not you're learning the concept, but you're also learning a skill here? Do you realize that this skill is more valuable than the concepts that you're learning here? So tell me, would you remember while you're waiting for the ambulance and you have injected hyaluronic acid? Don't worry, Sudesh. By the time you go for the exam, I would totally develop it and give you for life to use it, right? And that's the motive behind it. But tell me, would you remember cutaneous visual stroke, cutaneous visual stroke, cutaneous visual stroke? So you will check for the blanching in the skin. That is your cutaneous examination. Then you would check for the signs of visual deficit. How much can they see? How much can they not? And then you will check for the signs of stroke, which can be the facial weakness, unilateral weakness, difficulty with speech, right? So all these three important sign and symptoms. Now ADC gives you 5 other different things to check. Would you ever choose the wrong option or no? Now I put blood pressure, now I'll put pulse oximetry, and the options can go here and there. But unless you had developed this skill of memorizing exactly to the T in the exam, it is so easy to get confused, right? But not with this 100% preparation, paying attention to the details. And then after you have assessed them, if at all the practitioner who did it was actually an expert and kept the hyaluronidase also with them, then you will also inject hyaluronidase at there if you have it, right? And that is why if the question asks the professionalism questions, what are you going to talk to your associate about it? This kind of incident has occurred, to keep the hyaluronidase handy. Is that right or no? Right? So all these questions, all the things that we are learning here will be directly can be the part of questions, part of SVQs. So everyone understood the ocular emergencies. Now anybody close your eyes and anybody says the word ocular emergencies, the chemical one, the foreign object, the penetrating, the unilateral blindness, does it all naturally come to you or no? It will. And did it give you a pictographic? Did we not just have a complete visualization of what was going on while we were doing all this management? Were you not irrigating it? Were you not stopping the treatment? Were you not calling the emergencies? Were you not putting the cup on the eye? Visually, were you not with me? Right? 100%. And that is why, please, my dearies, if you want this to be 100% solidly framed in your mind, what are you going to do after this class? Tell me. Revise, repeat, right? Now tell me, respiratory emergencies, are we ready for it? The last section of the emergency department here. Water would be the best to prevent any kind of further irritation, right? If it was an oral tissue, saline has a different effect, but eye tissue is extremely delicate. That's why distilled water would be the best choice. All right, let's do the last leg now. Respiratory emergencies, extremely crucial, hyperventilation and asthma. Extremely important. And after we do these two kinds of physiological situations or pathological situations, after these two, the third one would be an accidental inhalation or swallowing. So 3 situations we are left with: hyperventilation, asthma, and inhalation or swallowing. Are we ready to do the 3 emergencies now with full confidence? So let's start with the hyperventilation syndrome. Hyperventilation, it is self-descriptive. Hyper, excessive. Ventilation means breathing. So over breathing. Patient would breathe rapidly, shallowly, and excessively more frequently. Correct? At least with the word you get the description. Shallow, rapid, and more frequent excessive over breathing. And this happens when mostly the patient is anxious or having a panic attack. Right? So usually with very minor causes like anxiety, right, or syncope-like situation, this would usually resolve within the 5 minutes with the correct management. Keep this thing in mind that I'm telling you right now. If your patient's hyperventilation syndrome is subsided within 3 to 4 minutes, less than 5 minutes, it was because of the minor situations, minor causes like anxiety, like syncope, right? Or a panic attack, psychological aspect mostly. But if it is not recovering in the 5 to 10 minutes or persists more than 5 to 10 minutes, then there is a more serious underlying cause and you need to call the ambulance. Would you remember this one? First takeaway from hyperventilation syndrome, all the questions would be around it. If it's few minutes only, the cause would usually be minor, psychological, like anxiety area, right? Or a syncope kind of situation where there's panic attack. Maybe the patient is nervous and he got hyperventilated. But that would usually by calming the patient, by stopping the treatment and then asking them to take a deep breath, mostly handling, psychological handling would suffice. Does that make sense, Elia? That only lasting few minutes would be because of the minor causes, non-severe causes, and handling the patient with calmness, asking them to breathe deeply, and then reassuring them. So, psychological management. Is that correct? So, if the cause is psychological, you will have to manage psychologically. So, you will tell them to deep breathe in, deep breathe out. That's what you do with your kids as well, right? When they are going all hyperventilating around yourself, right? You tell them to calm down. You tell them to deep breathe in, deep breathe out. Tell them that nothing is wrong, everything is okay. That's what you do. Psychological cause, address psychologically. That's all you need to do. Within few minutes, they will be all settled, right? Even better than how your kids settle. But rebreathing into the bag. Have you all seen that brown bag breathing in the movies and everything? We've seen that, right? So quite familiarity with breathing into the bag situation. We have been conditioned with a lot of media, right? What we have to unlearn is that is not recommended in your clinic. Will we remember that? And will we unlearn what we have seen in movies? Perfect. So rebreathing into a brown bag is not recommended. Now you will never forget these questions when they come in the exam. Is that correct or no? Wonderful. Now let's see if it doesn't relieve. So if its symptoms are still persisting and more than 5 to 10 minutes have gone, there is an underlying serious cause. And the serious cause can be cardiac, can be cerebral. Because respiratory system works either from the circulation or from the nervous system. Is that correct? There are two triggers for respiratory system. Is that right or not? Either cardiac stimulus or the cerebral. Anything wrong with the cardiovascular, lungs will obviously pause, right? That's where the circulation is going and coming and taking the oxygenated blood and everything, right? Similarly, the cerebral causes. So if it is not correcting, there is an underlying severe either myocardial cause, because we did in the question last time. We saw that cause of dyspnea, noisy breathing, myocardial. So sometimes in extremely diabetic patient where the neuropathy has occurred, they would not feel the chest pain, right? In extremely prolonged chronic diabetes where the neuropathy has occurred, patient would not feel the chest pain. And the symptom can only present in the forms of hyperventilation. Similarly, it can also be after an asthma attack as well, right? It usually asthma patients would know their history, right? So that is why if it's not relieving in 5 to 10 minutes, you will immediately call emergency and continue to monitor the patient until the assistant arrives. Unfortunately, with hyperventilation, there is no maneuver, there is no administration of an agent that you would do. Would you remember this one? So the patient can tell you in terms of symptoms that he's having some dizziness, some lightheadedness, shortness of breath, blurred vision. It can have tingling sensation, panic feeling. He can feel that he's dying. Patient can tell you that I feel like I'm dying. It may not be a true impending death, but the symptom would be of impending death. Symptom is what the patient feels and describes, right? And he can have a feeling of detachment from the external world, right? And signs is what you will observe. So you will not see that he's lightheaded. You will only see that he's breathing rapidly, or he's taking deep sighs between breathing, or that his consciousness is sometimes coming, sometimes going. You will not see that he's having tingling in the hands. That's a symptom that he will have. You will only see that he's contracting his hands involuntarily. So now, for example, if you have taken my TG quizzes, you know I confuse you a lot with symptoms and sign questions. And so does ADC in the bruxism, in the MPDS, right? A lot, right? So now let me give you a straightforward example here. In the exam, suppose you get a question about symptom versus sign. Now you will always remember if it was a sign question and the tingling in the finger, toes, and tips was added to the list and was asked what is incorrect. You know that can you see that patient is having tingling? Or unless the patient tells you, you'll never know that, right? So always choose between symptom and sign is if you cannot know something without patient telling you, that will always be the symptom. And what you see, right, is a sign. What you are seeing is a sign. What only patient can see or feel is a symptom. Is it a good way to remember or not? If inside a patient is lightheaded, can you ever see that? No. But the patient can feel that. And that will always be a symptom, right? Shortness of breath. And that is why that is a symptom patient tells. But taking deep sighing is an external thing that you are seeing. Blurred vision. He cannot see clearly. You will not know unless he tells you. So anything that you can't know unless they tell you will be a symptom. Will you remember it like that? Impending death, feeling of panic, dizziness, they are all symptoms. But what you can see, so let's say signs, rapid breathing. Patient will not know he's having rapid breathing. He doesn't know how many times he's breathing per minute, right? He'll just say it is difficulty in breathing. I can't, I have shortness of breath. That's all. I don't know I'm doing it rapidly or slowly. It's a sign that you are only seeing. He will not know whether he's passing out or coming out of the consciousness, right? That is what you are observing. What his heart rate is, only you can see, right? Whether he's contracting muscles or not involuntarily, you can see. Tingling, he can see, he can feel. So that's a symptom. So that ways you will remember the sign and symptoms and never forget these questions also. Never make mistakes in these questions. I have given you in TG practices as well. And management, you got it. Nothing you can do in the hyperventilation other than the psychological cause. Manage psychologically, just like you would manage your kids. Persist for 5 to 10 minutes. It's something serious. Please call the ambulance and monitor the patient. No paper bags, please, out of the window. Everyone gets it? Let's move to asthma now, shall we? Okay. Now, asthma attacks. Yes, absolutely wonderful. I don't even persist, Elia. Now, call dad is my first step. Just like call 000 in some of the situations is the first step. For me, call dad is mostly first step these days. And he's really pissed off because of this, but he's like, okay, you're not calling me really quickly. I'm like, yes, you're my emergency number now immediately. I don't wait. I just speed dial him. So let's come to acute asthma. And acute asthma can be fatal, we all know. That is why immediate understanding, observation of the signs, and then the management based on the minor or the moderate or the severe attack we are going to manage the patient extremely diligently. So if it's your repeat patient, you would know the medical history that he has asthma, and we have done those questions in the Mega Master file. Anyone here who remembers that? Ria, Ilya, Sudha, you all would remember, right? Koni, right? Perfect. So we have seen the asthma questions, and we know when there is a repeat patient, you always remind them to bring their asthma medication and the spacer along with them to each appointment. So they have to bring their inhalers. And sometimes patients who have severe asthma, wheezing can be missing, right? Wheezing can be totally missing. You will not hear those sounds, and you might just see them turning blue, cyanosis happening. That is loss of oxygenation of the blood. Is that correct? And that can be life-threatening asthma. In those situations, sometimes I'll come to that management, but sometimes even persistent salbutamol administration is needed till the help arrives when the cyanosis happens. So that's why in the question, if it asks, is wheezing a reliable indicator for the severity of the asthma attack? No. Sometimes it can still be a severe attack without wheezing. So don't think that wheezing will happen only then it's a severe attack. Cyanosis can also be the indicator. So if wheezing and cyanosis both are given you as separate choices and asked which will describe the severity of the asthma. Absolutely correct. Wonderful. You'll forget this concept ever in the exam? No. That's what I like to hear. Yes. So cyanosis indicates a life-threatening asthma or the severity and requires hospital transfer urgently. And what are the life-saving drugs for asthma? They are short-acting bronchodilators, salbutamol or terbutaline. Right? Now the asthma is categorized as mild or moderate, and then severe, and then life-threatening. They are the three categories. Let's memorize and be done with it so we never forget what decides mild, severe, or life-threatening. Are you ready for it? So cyanosis, always life-threatening. No consciousness, collapse, life-threatening. Blood oxygen saturation, less than 90%, life-threatening. These are the three key features for life-threatening. Cyanosis, loss of consciousness, or oxygen less than 90%. Even a single one of them is life-threatening. Right? Tracheal tug, subcostal recession, all the physical signs. Tracheal tug, abdominal breathing. Subcostal means below your ribs there will be depression while breathing, right? Because of the pressure and the exertion that the patient is taking to inhale. There is respiratory distress. Saturation values is 90 to 94. And using a lot of intercostal muscles, tracheal tug and subcostal recession. That means when the physical body is showing the sign of a strained breathing, that's a severe one. When the body has given up, collapsed, 90% down saturation, it has turned blue, that is life threatening. It has given up on it, right? Severe is when the body is physically putting all the effort. You're under the abdomen, you're under the ribs, your intercostal muscles, your tracheal muscle, everything is putting effort. That is severe. And 90 to 94 oxygen. Would you now remember this? Any physical signs present in the history, it would be your severe. And the given up state, less than 90 saturation, cyanosis, consciousness gone or collapse or exhaustion, and there is no even effort to respirate, that is life threatening. And mild to moderate is when he can walk around, he can still talk in one breath, whole sentence, right? And the saturation is still 94. Now tell me, would you remember this? Mild, severe, life threatening. Collapse, cyanosis, and saturation 90%, life threatening. Your tracheal tug, your subcostal recession, right? Inability to complete sentences, oxygen 90 to 94, intercostal muscle use, abdominal recession, subcostal recession. All these are physical signs where the body is putting a lot of effort, is severe. And mild is he can walk around, he can still talk in sentences, but the saturation has reduced to 94%. Now any of these keywords, will you miss that, please? So what is advised when you're giving the salbutamol inhalers? The most important device that you need is spacer. When you don't have spacer, that doesn't mean you will not administer the drug, but having a spacer ensures that there is a effective drug inhalation, penetration, and availability. Is that correct or not? That is why in the choices and the options, you will choose the ones with the spacers, and you know the reason why, for the better availability, better penetration into the lungs, right? And the better effectiveness of patient being able to intake the drug as well. But if it's not available, you're still going to do something about it. You're still going to give them the inhalers. Yes, if spacer is not there and you have nebulizer, that's your second choice. If nebulizer is also not there, Sandeep, then you will ask them to hold their breath for 4 seconds or as long as possible after each puff, so that now, Aarti, this 4-4 rule is separate, but the 4-second holding breath is not needed and is not part of 4-4-4 rule. That is only compensating for the spacer. Will you remember this, Aarti? The 4-4-4 rule is not for the spacer. The spacer 4-second will become the 4th 4, if that makes sense. Aarti, is that correct? Right? The 3-4s that you mentioned are the 4 puffs of salbutamol, 4 breaths in and out, and waiting 4 minutes, Geeta. Yes, with no spacer, it becomes 4-4s, because then you make them wait 4 seconds also after each puff. Right? So now, Geeta, let's talk about what's 4-4-4 rule. 4-4-4 rule is 4 puffs of salbutamol, 4 breaths in and out after each puff, and wait 4 minutes to give another 4 puff. Would you remember that? Everyone here. Right? Now, this is for the management of mild to moderate episodes. Is that correct? If it is improving after all these 4-4-4 technique, then it's fine. But if it's not improving, you will categorize it as severe attack, and then you will immediately call emergency. Alia, if no spacer, then after each puff, you will ask the patient to hold for 4 seconds. So that's another 4 value added, Alia. That becomes 4-4s, right? 4 puffs. After every puff, wait 4 seconds and then take 4 breaths in and out. After holding the breath, you will take breath in and out, not before holding the breath. Because you want to keep the drug in the mouth and don't want to expire it. Right? That is why 4-second hold, because whatever is in the mouth, you don't expel it out of your mouth. And slowly it goes into the lungs. You give it more chance to be in the mouth. That's what spacer also does. Agreed? So you will remember 3-4s and 4-4s now. Everyone. 4 puff, 4 breaths in and out, and wait 4 minutes. If no spacer, then 4 puffs. After each puff, wait 4 seconds. Hold the breath for 4 seconds and then take 4 breaths in and out, and then wait for 4 minutes for another 4 puffs, right? If it's still not responding, then you will categorize it as the severe one. And then once it becomes severe, it becomes, again, because the chances of it becoming life-threatening are super high, call emergency first. And then start supplemental oxygen and airway support. Why? Why? Anyone can tell why? because the blood saturation was below 90%. That's life threatening. Is that correct? And now, in severe episodes, anyone 6 years or above, you would give 12 puffs, not 4. And anything less than any child less than 6 year old, you will give them 6 puff. So remember, mostly 12 for 6 years and above, and 6 years and below, you will give 6 puff. So no 4-4-4 rule here. It becomes 6 and 12, and the age criteria is also 6. To remember like that. Age criteria is 6, and the puffs are 6 and 12. Age criteria is 6, and the puffs are 6 and 12. Would you remember this? But after that, if there is no spacer, holding would be 4 seconds. Breaths will be 4 in, 4 out, right? And then you will give for the next dose after 20 minutes. So it's not a 4-4-4 rule in your mild and moderate. It is kind of like a 12-6, then 4 breaths, and then wait 20 minutes. So it's very vague number to remember. Only the mild and moderate is fun one, but this one's not as fun, but the situation is also not fun. So it's serious business, serious numbers. 12 puffs, 4 breaths in and out, and 4 seconds holding if it was needed, if there was no spacer. And then repeat the dose at least every 20 minutes. And you can even continuously give salbutamol if it becomes life threatening. And you know the sign and symptoms of life threatening: blood saturation less than 90%, cyanosis, exhaustion, right? And collapse or reduced consciousness. Agreed, everyone? And continue to monitor till help arrives because you've already called emergency. If it was a mild attack and your patient has recovered, you don't need to continue and give them more time on the chair. Just temporize their situation and send them home and tell them to take their medication as prescribed, and also go and see their doctor what triggered the episode, or do they need any modulation of the drugs, right? Only after assessing them that they are healthy, they are now breathing comfortably, the vitals are stable, then discharge them. But don't try to complete the treatment even if they have recovered from a mild episode. Would you remember that? Similarly, you remember that syncope patient in a CHF patient, impending death situation. I've shared that article with you as well. And the patient had recovered. But did we continue the treatment for them? Would we continue the treatment for them? No. The medical assessment and review in that case is more so required, because any syncope in a CHF patient can mean impending death. So send to hospital or call ambulance, Aarti, if both the options are given, as we have in the exam, in the fall, in the Mega Master as well. Absolutely correct. You'll call the ambulance there, right? So that emergency, although not covered in the TG, but is also a very crucial emergency that gets asked in the exam, right? Now for the inhaled and the swallowed objects. So inhalation, and we did this in the yesterday's class also, so I'm sure you guys remember a lot of it. Inhalation is handled by, if there is no consciousness loss, by coughing first, and then 5 thrust, 5 back blows, and then 5 thrust. Will you remember this? See, if it is swallowed, first thing, you would assume that it can be passed out easily, but still medical assessment is needed. That is straightforward, clear for everyone. The swallowing, sometimes it can cause obstruction also. That is why medical assessment would be mandatory. But at least you know that it is not life threatening at that point. That's why send them to the medical assessment, and it can most of the times be managed easily. The crucial one is the airway obstruction. Airway obstruction happens with the aspiration or inhalation when it goes into the respiratory tract. So the respiratory tract can be partially obstructed or complete obstructed, right? So breathing is difficult, breathing is noisy, and you can still feel some air passing. That is a partial obstruction. Just trying to breathe, but no breath sounds and no movement of air coming from the nose is a complete obstruction, right? So airway assessment has to be known. You keep your hands under the nose and see the air is passing or not, emitting from the nose or mouth or not, and whether there is any sounds or not. So you hear for the breathing and you feel for the breathing. You do both, right? Yes or no? So in the exam, if I give you a question, signs of partial obstruction and complete obstruction, you would look at the options which are feeling and which are hearing the noise and feeling. And then visually you are seeing, yes, visually you are seeing whether there is any attempt to breathe or not, right? Now there is a way by which you can minimize the risk of the aspiration and swallowing as well, and that can become your professionalism questions and can be asked as what you would be telling your staff member or educating them. That would be by using your rubber dam mostly, or keeping a gauze behind the tongue, right? Or tying the instruments to the floss, high volume suctions, right? Putting the patient's head and tilting it to the side so that if it is just behind the tongue, it can still come out, right? And putting them mostly reclined rather than supine. And that is why we didn't put our patient in the recovery position after yesterday we discussed. Yes. So recovery is supine only, no? Supine and sideways. Recovery is you lie them completely down, fully flat, and then sideways. So by the time you put the patient in recovery, if something was still in the back of the throat, you would have made sure that it went either into the GI or into the trachea or oropharynx. Is that right or no? Upright is you would maybe thrust it through gravity in the front. But if you try to put them in recovery, imagine Genal. See, epilepsy has no threat of a foreign object in the mouth, Genal, right? So now that the object has gone, and it has gone under the throat, first you would do, and I told you yesterday also, if the option is to give in to look for the object in the mouth or clothes, that is your first choice after stopping the treatment. Look for the object and upright. Find it and upright him. After stopping the treatment, these two are priority. And then just hope it is gone in their stomach and they will pass it out in their stools. But if you see the airway signs, you can't find the object. You have to find the object. If you can't find the object, you put them upright, but the patient starts showing the signs of airway obstruction, noisy or less air coming, right? Then you would immediately call ambulance because it can become life threatening. It can lead to full choking. Yes, it's still partial obstruction, but still requires retrieval, right? So you'll call ambulance, Genal. Isn't that right? And you will, because the patient is still conscious, you can talk to them, reassure them, because breathing gets even worsened with the panic. So reassurance is needed here. We just did few minutes back. Reassurance, because that can trigger hyperventilation if he gets panicked. And that can further trigger the object down the throat. So then you start, ask them if they can try to expel it by coughing. So now memorize it like this. Patient is conscious. He can listen to you and he can do what you ask him to. You need the patient to be conscious and you need airway obstruction signs to be doing this. First thing, cough. Second thing, five back blows. And third thing, five chest thrusts. So a conscious patient, three things in the same sequence. Cough, five back blows, and five chest thrusts. Would you remember this? Cough, five, five. Would you remember? Cough, five, five. Patient is conscious, cough 5-5. You'll ask him to cough. If not, 5 BB, 5 CT. Aarti, you're getting the drill, right? So that is what we do when the patient is conscious. And when the patient becomes unconscious, then again, you have to call emergency. That's for sure. Any sign of airway involved, emergency is the number one. And check for the object also. But because they have lost their consciousness, what are you going to do? The moment patient loses consciousness in our clinic, we start CPR. And abdominal thrusts or Heimlich maneuver. Would it, would it be recommended for any kind of choking? No. So that is partial choking, right? Where the patient is conscious. Also, we have seen those scenes in movies, right? Heimlich maneuver in the restaurant. Olives mostly. That's what they are, right? A very nice date night and a very nice drink going on, and the olive does the job. And then they do the Heimlich maneuver. Are we gonna unlearn that or no? Or the ring in the wine journal? Perfect. How could I forget that? So tell me, are we gonna unlearn that or not? Now in the exam, are we gonna choose the wrong options ever for the paper bag or the Heimlich maneuver? So leave that for the movies, not for the clinics. What we remember for the clinics? Cough 5-5, right? 5 back blows and then 5 chest thrusts. Absolutely correct. And there's a risk of internal organ damage. That's why we don't recommend Heimlich's maneuvers. And that, my dears, ends the medical emergencies management. I hope you guys had fun and a lot of learning and realized the fact that no matter how simple some tables or some written context might seem in TG, how complicated and how tricky it can still get in exam, and how in-depth preparation you need to master it. So good to see you here, Carla. So thank you so much. It was a wonderful, wonderful evening. And you guys were a great audience as always. I had fun and I hope you guys had fun too. Thank you so much. I'm truly grateful for all of you for giving me a fabulous time. You take care as well. I'm going to announce about the mock exam. Yeah, the public mock is coming, guys. But not this week. So next week we are having the public session. I'm going to announce the topic, the poll. And then we're going to have a public session on, the public mock on the first week of August, right? So great things coming ahead. And then another ninja mock for the Winspert candidates. That's coming in August as well. And then what comes after ninja mock in August? The one thing that we've all been waiting for before exam, our grand mock, right? So I'm super excited and all the exciting things to look forward to. Isn't that right? So who says preparing for ADC or any licensure exam can be boring, can be chronic, can be painful, has to be stressed, has to be dramatic? Does it have to be? Results are not in our hands, but how we handle the process is absolutely in our hands, right? Our attitude is everything, and trust the process, right? Thank you so much, guys. Have a great night. No social media whatsoever. Take rest and let the information seep in. And I'll see you guys, the Winsperts, tomorrow for the internal advanced file class. Absolutely right, Kiran. I also do that with you guys. I sometimes go very smooth on you and I sometimes go very hard on you as when it's needed. So I think a little bit of balance goes a long way. So let's see each other tomorrow, guys, when we do our advanced file from page number 121 till page number 128. And yes, Bye. Take care. I'll see you tomorrow. Thank you. Bye bye.